So, welcome everybody to the first ever Response Center lecture series. This is a lecture series where we hope to invite thought leaders in the field who've had great impact in their respective fields. And it's an opportunity for us to not only disseminate knowledge amongst the group, but also to network a little bit and engage in some professional development. So it's my honor to introduce Dr. Wright, Dr. Robert Wright, who is a pediatrician, a medical toxicologist, and an environmental epidemiologist at Sinai. He's the Ethel H. Wise Chair of the Department of Environmental Medicine and Public Health, and he co-directs the Institute of Exposomic Research. Did I say that correctly?
Yes, I've heard many different pronunciations, so I accept all of them.
Great. And so his lecture is about environmental health and precision medicine. Without further ado, take it away, Dr. Wright. And it's great to have you. I'm very excited about your talk.
Thank you, and thank you for inviting me. Um, so for those of you who studied literature, Flannery O'Connor is a very famous writer from the South, and she wrote a series of short stories, one of which was called "Everything That Rises Must Converge." And so I use it as a subtext of this talk because both precision medicine and exposomics are rising, and hopefully they will eventually converge. So this is an outline of the talk. So I think most people have heard that precision medicine or personalized medicine is the future. Exposomics has been growing at entrance. Exposomics is the environmental equivalent of genomics. So genomics is to genetics, as exposomics is to environmental health. And then, so it's a measure of all the different environment. And then part of the talk will be on how can we apply exposomics to understand health and disease, and can we can we combine medicine and public health together and conduct research with this sort of lens so that we don't think of precision medicine as purely being a genomic field, which is really the way it's practiced present. So in other words, now is the time to converge. So first, again, I'll go back to what is exposomics. It's the study of all the health relevant environmental exposures that we come across in our lifetime. It's not just chemicals, it's also allergens, vector-borne diseases, infections such as even COVID, viruses, bacteria, the microbiome. It's our social environment, it's our nutritional environment, it's our physical environment, and everything, including chemicals. So as I said, it's a study of all the health relevant environment we experience across our lifespan. So it's a very large area to get into. It's very interdisciplinary, and the field hasn't completely worked out how it's going to measure all of these issues. But there's been a lot more advance, I think, than most people realize. So if that's exposomics, and what is precision medicine? So this is the National Research Council definition. It's the tailoring of medical treatment to patient characteristics. And the idea is that we can create susceptibility, classifications to disease, its prognosis, or even a patient's response to treatment. We can individualize interventions if we can do this, and that would maximize benefit, reduce treatment failures, reduce side effects. It really means understanding every patient's individual background and how that's going to affect their diagnosis, progression, and treatment. And it operates in a setting where the probability of illness is 1. So public health operates in a setting of prevention. At that point, we don't, and primary care does as well. So at that point, we are trying to prevent a disease from occurring. In medicine, the disease has occurred, and now we're thinking about diagnosis, progression, reducing the progression rate, or providing an intervention or treatment. That's going to come into play a little bit. So precision medicine right now is really practiced as a pharmacogenomic field. So almost all the programs really exclusively focus on genomics. The idea is if we understand genetic variation to treatment of disease, we can target therapy to the most effective drugs, improve efficacy, decrease toxicity, and target behavioral modifications. That would improve counseling and decision-making, and also improve patient outcomes and satisfaction. But it only would work if genes are the only source of variation in treatment and prognosis. And there's very little reason to believe that that's the case. In fact, if you were to look at various websites for precision medicine programs at different institutions, and these are just some examples, every one of them will have a picture of DNA in some form. Every one of them will talk about the genes that cause disease and targeting drugs based on the genes that get discovered based on sequencing or whole exomes sequencing, GWAS, etc. And yet we really know that this is just one piece of a very bigger puzzle. And in fact, for most programs, there's no mention of environment. So this is one in which there's no mention of environment. Here's another that's oriented horizontally instead of vertically, but still basically has the same sort of DNA, pills, and risk stratification with no mention of environment. And then here's one in which there is a little bit of mention of environment, but again, it really focuses on DNA. And yet we know that genetics isn't the only cause of complex diseases. And we've known this for a really long time. This is the cover of Science in 2002. The introductory commentary is actually titled, "It's Not Just the Genes." And there were articles about behavior, nutrition, infections, chemicals, physical environment, culture, society, and stress as actually predictors, as risk factors for complex diseases. And the complex diseases are the diseases that really are driving healthcare costs. They're Alzheimer's disease, Parkinson's disease, autism, asthma, cancers. All those are complex diseases in that they're not just caused by genetics, they're caused by a mix of genes and environment. So how did we get here? So as I said, the complex diseases, and this is just a partial list, include things like attention deficit, hyperactivity disorder, obesity, asthma, COPD, renal failure, Parkinson's disease, cancer, Alzheimer's disease, etc., and many, many others. Well, we know that their etiology is a mixture of genetic and environmental risk factors. We also know that they're getting more common. Most of those diseases on that list are more common today than they were 10 years ago or 20 years ago. Genetics cannot explain an increase in rates over a 10 to 20 year time span. Genetics requires multiple generations to pass. Genetics would require centuries to explain the increases in those diseases. It has to be environmental. There is no possible way genetics can explain those increases. But the environmental risk factors for most of these diseases are actually largely unidentified because there hasn't been an investment in trying to find them. And in fact, I think the language that we use tends to create barriers. So we talk about nature versus nurture. When we talk about environment and genetics, we do studies on heritability, in which we enroll twins, and we claim that X% of a disease is genetic and X% is environmental, when in fact, genetics for all complex diseases really confers risk. It's not really causation. You just have a higher risk. Just like if you smoke, you have a higher risk of lung cancer, but it's not deterministic that you're going to get lung cancer. That is, environment confers risk, and rarely is it truly causative, other than obviously getting hit by a car or shot by a gun. And the levels of the risks vary for each the genetic factor and the environmental factor. So if we take a step back and we ask ourselves, why do we even call diseases genetic or environmental? What's the underlying rationale for that? Well, I'm going to make the argument that if a disease is due to a gene-environment interaction, that this is actually a very superficial and unstable estimate. So if a disease is due to genetics and environment both, and they interact, if the genetic polymorphism is uncommon in a population and the environmental factor is common in the population, the disease will appear to be genetic. And the converse is also true. If the environmental factor is rare, but the genetic factor is very common in a population, the disease will appear to be environmental. Now, this is a concept that's hard to see in human populations, but it can be illustrated with chickens. So there actually is a trait in chickens called yellow shanks. And so I'm going to make an argument that yellow shanks is actually due to a gene-environment interaction and has a variable heritability. So this is a discoloration of chicken legs if you have a particular genetic variant, and the chicken is fed yellow corn as opposed to white corn. And this is actually out of a textbook by Ken Rothman, who's a very famous epidemiologist. The genetic variant follows an autosomal dominant pattern. So let's say you have two sets of farmers, Farmer Jones and Farmer Smith. Farmer Jones has an inbred chicken flock. All of those chickens carry the variant for yellow shanks. For generations, his farm has fed them white corn. One day the store runs out, he has to feed them yellow corn. All of his chickens will get yellow shanks. If you ask Farmer Jones, what's the cause of yellow shanks? He'll say it's environmental. It's due to yellow corn. Down the road, there's Farmer Smith. He has an inbred chicken flock. None of them carry the variant for yellow shanks. Yellow corn is cheaper than white corn, so his family's been buying it for a long time. Nothing ever happens. One day, a chicken gets yellow shanks. And he's an amateur, geneticist. He creates a pedigree, and he notices that half of the offspring of that chicken get yellow shanks, and of the ones with yellow shanks, half of their offspring get it, and the other, without yellow shanks, none of their offspring gets it. So he draws a pedigree, and he reaches the conclusion that yellow shanks is a genetic disease that follows an autosomal dominant pattern. So who's right? Biologically, the exact same thing is happening in Farmer Jones's chicken as Farmer Smith's chicken, but the perception is radically different in the two. And it's all because of the distribution of the environmental factor and the genetic factor. So is yellow shanks environmental or is it genetic? And by the same token, if we think the same thing is happening in humans, and it almost certainly is, can we really call cancer environmental or genetic? It's really due to the prevalence of the genetic risk factors and the environmental risk factors, which are largely unmeasured. And even in what we think of as a Mendelian genetic disease such as phenylketonuria, is it really purely genetic? Because if I don't feed a child phenylalanine early in life, I can actually prevent the disease from occurring. So even that's due to a gene-environment interaction. In fact, virtually all diseases are actually due to gene-environment interactions. And in this context, how can we calculate the heritability of chicken shanks? In one case, it's 0%, and in the other case, it's 100%. And that just illustrates how heritability can be very, very misleading. And in fact, there are many studies of heritability, say autism. There are some studies that got a lot of attention. They claim that autism is 100% genetic. More recent studies have actually claimed it's closer to 50%. And that's probably due to the varied distribution of the genetic and environmental risk factors in different populations that were studied. Because all genes operate in variable environmental backgrounds and vice versa. And there's lots of backgrounds. Nutrition is a background. So we know that obesity can affect metabolism of drugs, particularly fat-soluble drugs. So can mineral or vitamin deficiencies. Pregnancy clearly has a big impact on drug metabolism. Geography can even have a big impact. Temperature and allergens, or even altitude. You're far more likely to have a sickle cell crisis if you're living in Denver than if you're living near sea level. Culture plays a role because culture has behaviors that lead to exposures, and there are mixtures of chemicals that vary from person to person, and even health status can affect drug metabolism. When I was a resident many, many years ago in the late 1980s and early 1990s, we used to give theophylline for asthma. And if you developed an influenza infection while you were taking theophylline, it changed the metabolism of theophylline, and you might see theophylline toxicity because it inhibited the enzymes that metabolize theophylline. So health is a major, major background. In fact, it's probably the most important background in precision medicine. So here's some examples of how precision medicine might be practiced. So why is this important? A 53-year-old, this is the standard example of why we need genomics in precision medicine. A 53-year-old develops a DVT on a trans-Pacific flight. She develops a GI bleed after she starts a standard dose of warfarin. And this is actually a very good example of how genomics can actually be very useful in precision medicine. She has a genetic variant that makes her a slow metabolizer. So there's another example, though. A 17-year-old child who has autism has notable increase in head banging and anger outbursts. A genetic screen doesn't find any potential cause for this. Remember, we think autism is a largely genetic disease. Well, it turned out this particular child actually had lead poisoning. Because he had autism, he was prone to pica, eating non-food substances, and he was eating newspaper. And newspaper ink, in this case, actually had some lead in it, and he was eating enough newspaper and digesting the ink that he would actually develop lead poisoning. And so when we treated his lead poisoning, his head banging and anger outbursts noticeably improved. And in fact, his blood lead was at 73 micrograms per deciliter, which is obviously very high. His 3-year-old brother, who does not have autism, and this is actually a real case, had a blood lead of 2 micrograms per deciliter, which is within the normal levels. And 2-year-olds are actually the age at which you typically see lead poisoning. You don't typically see it in a 17-year-old, but in this case, because he had autism, he was more likely prone to it. So his background was actually the disease that actually made him prone to getting this disease, lead poisoning. So his autism made him at risk for lead poisoning. So here's another example. A 14-year-old who has GE reflux and history of depression. He's treated with codeine for a fracture, reports no improvement in the pain. So a genome scan is done because it's been reported that there are functional variants in phase 1 enzymes in particular that affect codeine metabolism, prevent its conversion into morphine, and that's why codeine is sometimes ineffective. Well, he doesn't have one of those. So what do you think caused it in this case? So I gave a couple of clues. He's got GE reflux. Maybe he's taking Tagamet or Zantac over the counter, and he has a history of depression. Maybe he's taking Paxil. Both of those are P450 enzyme inhibitors that can actually interfere with metabolism of codeine, just like the genetic variants can, inhibiting the metabolism so that it's not converted into morphine. That's why he didn't have any improvement. So a genetic scan would not have prevented someone from getting codeine, and yet it was ineffective because of his environmental co-exposures. So what are the most important backgrounds in precision medicine? Well, it may not be genes or environment, but disease and treatment. So in those cases that I gave, the disease was actually the most important background, or the treatment for those diseases. In one case, it was autism. In the other case, it was GE reflux and having depression treatments. And those actually interfered with the treatments, the medical treatments that were being provided. But genetics would not have predicted the need to actually find alternative treatments. So in environmental health, we tend to be very public health oriented. We tend to be very focused on preventing disease. But if we're going to move into the precision medicine field, we have to start thinking about doing studies that physicians can use in order to treat patients more effectively. Right now, we're really not doing that in environmental health. So obviously, to this group, I give this talk a lot to public health groups. So from a medical perspective, we want to understand how we can diagnose a patient. Exposomics and epidemiology might help. If I'm a 60-year-old man, if I come in with chest pain to the emergency room, particularly if I'm a smoker, you might think that I'm having a heart attack. And so they are kind of a weighted variable that you will use in making a diagnosis. But in terms of treating the patient, it doesn't really help very much. It doesn't really matter at this point why I am having a heart attack. It really, in fact, you probably don't care at this point why I'm having a heart attack. You only care that I'm having a heart attack and what you're going to do for it. In that case, the fact that I used to smoke doesn't really matter that much. I will probably quit smoking as I'm told to do it because I've had a heart attack and I've probably been told for years to do that and I ignored it, but now I'll probably start to listen. But the fact that I smoke does not affect the treatment. So environmental health has actually been asking the wrong questions if we want to move into the precision medicine field. We need to start asking questions that are more relevant to a medical perspective. So where are some of the roadblocks? So medicine works at the individual level. In terms of diagnosis, we want to know what's going on, but clearly there's a problem somebody has presented. So they have some issue that they want treatment. So in public health, we're dealing with healthy people, many of whom have no symptoms whatsoever. So that's a very different dynamic. And we're talking about treatment. We're not talking about prevention. We want to limit side effects. We want better outcomes. So environmental health is really a public health field. And so we don't operate at the individual level. We operate at the population level. And we're thinking about prevention. So we're thinking about risk factors. So if I smoke, will I have a heart attack or will I get lung cancer? There's a probability of that happening. It hasn't happened yet, unlike in the medical perspective in which something has already happened and somebody already has a disease. Obviously, primary care is a little closer to public health. But we're really focused on prevention. And we're thinking about susceptible populations, like such as, say, people who smoke or people who are exposed to high levels of air pollution, for example. Medicine starts after the person is sick. Public health tends to start before a person is sick. Outside of primary care, medicine is less interested in why you're sick, but rather how to treat the patient. And this is really what it looks like if you were to graph public health research versus medical research. So on this graph, the x-axis is time, and the presence of a disease is this little hashtag in the middle of the x-axis. And in most public health studies, we do either prospective cohort studies or enroll healthy people where you follow them until they get sick. The Nurses' Health Study in Boston is a really good example of that. They've been following 100,000 nurses since the 1970s, and they've documented their illnesses over the years. Takes a long time to do a prospective cohort study and a lot of money. So most research is actually a case control study. So you enroll people with a disease, enroll people without a disease, and you try to go back in time to see what their risk factors are. You can get to the same place, but there's obviously issues with case control studies with respect to recall bias, and sometimes it's not easy to reconstruct the past. So there are advantages to prospective cohort studies. Most genetic studies are case control studies, or they're what are called family-based association studies. And those are a type of matched case control study. So you're enrolling people who have a disease. So the enrollment is contingent on having a disease. So it's not a prospective study. And then when you think about treatment, it's usually a randomized controlled trial, or RCT, the medical perspective, how to treat a patient, or you're doing a clinical observation study. So you're watching patients who have Parkinson's disease, and you're trying to figure out whether or not there are risk factors that indicate that they're going to have a more rapid progression. But in public health research, the outcome or the phenotype is not present at the beginning. And in medicine, we only study the people who have a disease, and we randomize them to different types of treatment, or we observe them and see what happens over time. So public health, therefore, deals with causation and risk factor, and medicine deals with diagnosis and treatment. So environment has done very little work in the diagnosis and treatment area. And I think that's something that I hope in the next 10 to 20 years starts to change, because precision medicine studies really should start after the disease onset and then move forward in time and assess the disease progression, whether it's getting better, worse, or the same. So why now? So there's actually been a lot of advances in what we'll call exposure science in the last 10 years. And exposomics is really an exposure science. We're just measuring the exposome. We want to be able to relate it to health. Most of the research is actually done as how to measure more and more of the exposome. Just like early on, genomics was interested just in measuring more and more genetic variants until whole genome sequencing became more cost effective. But for the first 10 years of genomics, most of the advances were actually in measurement. So this is what's happening now in exposomics. So we have untargeted chemical assays. So actually our laboratory here at Mount Sinai does these. These are analogous to untargeted metabolomics studies. Metabolomics is studying endogenous breakdown chemicals from your diet. Exposomics is in measuring them because those tend to be in higher concentration, so they're easier to measure, but we're also focusing on the lower concentration exogenous chemicals, the things like phthalates or forever chemicals, PFAS, perfluoroalkyl chemicals. Those are included in untargeted chemical assays. And we also have higher dimensional targeted chemical panels. This would be a talk in and of itself, but untargeted assays are not truly quantitative. They're actually semi-quantitative, whereas targeted assays actually are fully quantitative. And now in our laboratory, we're actually able to measure both endogenous and exogenous chemicals in targeted assays. And some of our panels that we do actually measure several hundred of these chemicals simultaneously. So we're getting bigger and bigger panels. And the panels would be like microarrays in genetics. And the untargeted assays would be sort of like GWAS or sequencing. And then there's a lot of environment which can't be measured in an assay. So air pollution, there is no assay for air pollution. Temperature, we also believe that green space and light at night have health effects. Noise has a health effect. There is no assay to tell you how much noise you're exposed to. So a lot of work is now being done in remote sensing, particularly satellite remote sensing. So in our department, we have several geographers who are actually data miners, that actually can create models of air pollution that actually go back in time, because the satellite data goes back to whenever the satellite was launched, and actually can tell you based on your address how clean the air is in your neighborhood. So we do have ways to reconstruct environmental factors such as that. Plus, there are ways to measure the built environment. There are scales for walkability of neighborhoods. There's public database mining to look at SES in the local socioeconomic status in the local neighborhood. I mean, a lot of different social variables, such as neighborhood crime levels, can all be measured with public database mining. And if you link that with electronic medical record mining, you can start to do some really interesting environmental health research that relates to clinical outcomes. There's also wearable devices. Probably everybody here, or maybe not everybody, but a large proportion of the audience probably owns a smartwatch. Apple or Google or Garmin knows exactly where you are right now, depending on the brand of Fitbit of the smartwatch that you have or the cell phone that you have. And those wearable devices also can give you some physiologic information and even some phenotype information. But if they're combined with the satellite remote sensing data, you can actually get really fine scale measurements of, say, exposure to air pollution, because a lot of times you can actually tell whether or not somebody's indoors versus outdoors based on the cell phone signal. And then all of this requires a big data computational infrastructure, but because of genomics, in which we're measuring 4 billion base pairs using whole genome sequencing, that computational infrastructure largely exists in most institutions. So the ability to crunch these large amounts of data is already in existence. So in summary, so with respect to public health research in medicine, public health is interested in studying vulnerable populations, but has largely ignored the role of environment in the response to treatment to a disease. It's largely ignored the effects of environment on people who have a disease, that is, with regards to the severity of that disease or the rate of progression of that disease. And perhaps the largest vulnerable population to environment may be those who have the chronic disease, but we're not really studying their environments. A lot of environmental health research, say, looks at plastics and whether or not that is a risk factor for obesity or type 2 diabetes. Well, there are millions of people with obesity and type 2 diabetes in the United States, and there's very, very little research on what exposure those plastics are doing. And they actually may be exacerbating their disease. And yet we don't really study that. We only study it with respect to causation. We really need to start moving to the right side of that figure that I showed, and start studying the impact of environment on people who have a disease. So this is an example from untargeted chemical assays. So this is a chromatogram. So we do a high resolution mass spec assay. We can measure approximately 100,000 chemicals in a biological sample, whether it's serum, plasma, or urine. Sometimes it's actually better to measure things in urine than in plasma. So in the ideal situation, you would actually use both. But it may aid in diagnostics. So if you could even do this in, say, a case control study, imagine patients who have bulimia, and in which you're not clear about the diagnosis. There may be a chemical signature from bulimia that may actually be diagnostic. So there's needs to be more work in using untargeted assays in people with diseases. And we could even focus on cases only. So if you had, say, Parkinson's disease or lung cancer, what is the change in these assay? What is the chemical signatures in people over time? Some of these are metabolites, some of these are exogenous chemicals, but they may actually identify why some people's disease progresses faster than other people. So we need to do these sorts of serial measurements of people over time who have a disease. And so how might we operationalize exposomics in patients? So as I said, we should be running untargeted assays in cohorts of patients longitudinally so that we can predict risks of complications while they're getting treatment and predict response to treatment. I sample them prior to starting the treatment and seeing whether or not there's a signature that we can see looking backwards that would have predicted that this patient responded, whereas this other patient did not respond. And this could be done in new clinical cohorts, or if we have samples from randomized controlled trials, we might be able to find signatures. Genomics has been doing this for a while, not with a huge amount of success, I would say. Perhaps if we added untargeted assays to randomized controlled trials to try to understand treatment failures and treatment successes, we actually might improve our signal. So study design matters when applying exposomic data. And then there's wearable devices. So I think the Internet of Things is sort of falling out of favor as a description, but it refers to phone apps, cars, appliances, and sensors. And these are devices that exchange data through the internet with other devices. It can download GPS coordinates and physiologic data so you can know where you are when your heart rate goes up and know your movements, whether you're running or walking, and also the quality of the air you're breathing. So it may be that we'd be able to more finely pinpoint the effects of air pollution, say, on cardiovascular function or cardiopulmonary function. And there's even an exposomic wearable device. So this is a wristband. There's a company called My Exposome. Our lab will actually analyze these wristbands as well. So basically, the idea is you wear it for a week. Whatever in your environment will land in it. So we'll measure that in an untargeted assay. We can tell you what you were exposed to over the last week. We can't tell you the exact day you were exposed, but we can tell you what you were exposed to during that time. And people also put these in their homes, and we use as passive samplers. That's another way that we've used them. Um, so with respect to wearable devices, and with respect to public health epidemiology, they don't really help that much in disease management. If you give those wearable devices to people who are healthy, it can help prevent disease if you know that you didn't get your 10,000 steps in today, and it helps with tracking and it helps with all that. But maybe it's more important to put it on patients with Parkinson's disease or Alzheimer's disease or cancer so that we can see the effect of exercise on their health outcomes as well. We've really primarily done this in well patients. And there's been some research, I don't want to overstate that there hasn't been any research, but I think there's a big open field for actually putting these devices on people who actually have a disease and do more medical research on disease cohorts. So we can track the response to treatment and progression, track activity exposure during chemotherapy or Parkinson's disease, as I said, look at heart rate variability and air pollution after coronary artery bypass, or even link untargeted signatures to high-risk electrophysiology phenotypes. In fact, one of the favorite studies I like to cite, there was a study out of University of Washington that looked at air pollution in patients who were post-lung transplant and saw that their 5-year mortality plummeted if they were in an area of high air pollution. It might seem kind of obvious that that would happen, but how often do you think they get advice about using HEPA filters and air cleaners about and how that might actually prolong their life? So there's lots of work I think that can be done on potential environmental interactions that may actually improve patients' life or even their survival in some cases. And then there's all kinds of work being done with remote sensing. So as I said, we have several geographers in our department that actually measure things like climate, looking at temperature and other climate variables, exposure to natural spaces or green spaces, which is this figure here, daily air pollution, traffic patterns and noise, access to healthy foods. We can actually map out whether or not there are bodegas or grocery stores or other types of food in your area. And you can even mine social media. So the bottom left is actually a paper that was published by Itai Klug in our department, who actually used natural language processing to find mean words and tweets and plot their geospatial distribution, so you can see where all the mean tweets were coming from. But how might you operationalize the exposome? So we can use wearable devices. We can measure activity, air pollution, temperature, physiologic data. If one day you go into your doctor's office and you'll hand them your wearable device, they'll download all this information and they can tell you how much you've been exposed to air pollution, temperature variability, and the physiologic response to that. They can take your address and occupational history and download all this information from your cell phone, and then they can couple it with an untargeted chemical screen, and then AI can do one day risk scores, like polygenic risk scores, but these would be polyexposomic risk scores, to actually tell the patient about their risk for a particular health outcome. And in fact, maybe one day we could do exposome by genome interaction so we can understand sort of why chicken shanks happens and that there is a genetic susceptibility and environmental susceptibility that interact. And I think this is the goal one day for precision medicine, to actually be able to use this information clinically, because it's clear that environment plays an important role, not just in disease causation, but in response to treatment. So here's some examples of precision medicine projects. I think they're very low-hanging fruit. Patients who have cystic fibrosis, well, cystic fibrosis obviously is a genetic disease. However, they get asthma, phthalates, which are plasticides, have been associated. Excuse me, they don't get asthma; they get lung disease. Phthalates have been associated with asthma, so they actually do impact the lungs. Phthalates have also been associated with type 2 diabetes. Cystic fibrosis patients can have diabetes. Cystic fibrosis patients live in the same world we do. And they are probably exposed to lots of phthalates. They may be exposed to more phthalates than us, because phthalates are actually found in IV bags, and they're much more likely to get IV fluid over the course of their lifetime than patients who don't have cystic fibrosis. So phthalates may be playing a very important role in disease severity and progression. We don't really measure environmental obesogenic chemicals. So obesogens are compounds that are thought to promote type 2 diabetes. They include or compounds like phthalates, but they also include PFAS, which are often referred to as forever chemicals. We think that they're a risk factor for developing diabetes, but there are almost no studies on what they're doing to patients with diabetes. And there are millions of patients with type 2 diabetes in the United States who are being exposed to all of these chemicals, and we don't really understand what they're doing with their disease progression or severity. And then there's things like neurotoxic metals. Lead and mercury and arsenic have all been studied as neurotoxic metals. Some of them have even been linked to things like Alzheimer's disease, but we don't know what they're doing to patients who already have Alzheimer's disease. Maybe it's actually causing a more rapid progression of their illness. This is another area that's really open for investigation. Even things like air quality in surgical ICUs is almost never studied. And yet there may be particulate matter at a high level, because internal air is very difficult to predict. You really just have to measure it to know how much particles are in the air internally. Ventilation varies from building to building. For all we know, there's a lot of poor air quality in surgical ICUs, and that might be actually impacting their outcome at a population level. It's probably not going to necessarily be something that you'll see at an individual level, but if you looked at over time, the ICUs that have cleaner air might have better outcomes than ICUs that don't. And then, as I think I mentioned earlier, that you could use untargeted chemical assays to look for signatures that might be diagnostic of diseases like anorexia or bulimia. So you can make early interventions. But anyway, unlike causation research, the field is really open. And so most of the ideas really are very low-hanging fruit. You can almost say, if I've seen studies that link an environmental factor as a cause of a disease, turn it around and say, well, what happens if you already have the disease and you're exposed to this environmental factor? And that's basically the game that I played with that last slide. Exposomics is a very interesting field. It's probably the most interdisciplinary of all the omics sciences, and it has very different data requirements because it generates very different types of data. So it can be questionnaires. There'll always be a role for questionnaires. We're not going to be able to go back in time and understand things like childhood trauma or physical abuse unless we ask questionnaires. So, and also occupations are something that are very, very important. We need questionnaires for that, but it'll also include GIS-based environmental data. It'll one day include pictures, so understanding your environment. Might even be taking a picture of underneath your sink and seeing what chemicals that you use to clean your home. That could be important environmental information that could be one day used, linked with AI to actually generate risk scores. There'll always be biomarkers in different media, whether it's urine or blood or even breath condensate. One of our faculty, Manish Arora, is a dentist and a chemist, and he's actually developed methods for analyzing chemicals in teeth. And there's a growth pattern in teeth that's analogous to trees. They have daily growth rings, so we could actually attach a calendar date to measurements, and he can do hundreds to thousands of measurements in a single tooth. So not just one measurement, but thousands of measurements and linking them to calendar dates at the same time as possible, actually, with deciduous teeth, baby teeth. It can also be done at time of autism. He's published some interesting studies with ALS, Lou Gehrig's disease, in which they've actually gotten teeth at autopsy from patient or postmortem teeth from patients, and actually shown differences in different chemicals between the patients who had ALS and the control group. And there'll always be a place for mobile devices as well. And one day these methods should be linked to genomics, epigenomics, transcriptomics, etc. So the future of exposomics and precision medicine is going to enable more diagnostic tests so that we can understand subpopulations that have different prognoses. I think we'll better understand by using exposomics the relationship between a patient's chemical, nutritional, social environment and their disease prognosis and response to treatment. And hopefully we'll be able to identify optimal treatments by using exposomic data so that we reduce the variability of response, side effects, and improve compliance. So that one day precision medicine programs will look more like this. So instead of being purely based on genomics, they include other types of environmental factors as well as genomics and integrate what our backgrounds really are, because our backgrounds are not just purely genetic. Our backgrounds are very large, perhaps an even larger proportion than genetics are actually due to variations in our environment. So our institute has invested heavily in being able to measure the exposome, so we can do untargeted chemical assays, metabolomics, measurements of diet. We have some novel biomarkers, as I mentioned, Dr. Rora. This is a figure from a paper that he published in Nature, and we can measure organic chemicals and trace elements and metals, and all that could be linked potentially to other types of omics data as well in research, so that we can complete the complex disease puzzle. I think that's my last slide. By asking the right questions. So, so some of this work is supported by our CTSA, as well as a center grant, and a grant from the National Institute of Health called the Human Exposure Analysis Resource Grant, or HERE. And I'm happy to take any questions.
Thank you so much. What an incredible discussion, and just thinking about exposomics and how we might be able to incorporate that into, you know, potentially some of the research that we do. And I'm definitely going to steal that quote about there are no right answers to the wrong questions. So thank you for that. And I know that there's some people in the group who are going to have some questions for you, but I'll kick us off with a question about how, you know, you talk about potential future directions and some of the existing studies going on in the realm of exposomics. And I'm just trying to figure out how we could potentially incorporate exposomic principles into our studies of clinical toxicology, for example. You know, we've got patients who are coming in who have probably a variety of different exposomic profiles. They're, you know, obviously exposed to all these drugs, and they've got genetic makeup that puts them potentially at risk. Do you see, you know, a role for incorporating that into some of the studies that we're doing clinically?
Yeah, you know, a lot of people take over-the-counter drugs, so they may not list them when you ask for their medications. There are dietary factors like grapefruit juices and other juices that affect drug metabolism. An untargeted assay could potentially pick that up. And I think if we're truly thinking that we're going to use, you know, genomic data to guide our treatment, I think we really need to think about how we could use environmental data as well to guide our treatment. And I think it will make our, you know, precision medicine more precise if we do that, because you can get to the same place by inhibiting an enzyme as having a genetic variant. And I think somewhere along the line we sort of forgot that. You know, back when I was training in the 1990s, that was discussed all the time. You know, things like, you know, is your patient taking grapefruit juice? You know, could that be the reason why they're not responding or not metabolizing correctly? And drug-drug interactions are really analogous to exposomics, but, you know, a lot of these interactions go beyond polypharmacy, and they could just be environmental factors. And so I do think that one day, particularly with the use of AI, we'll be able to do a relatively rapid analysis of a patient's risk and probability of response to disease if we know more about their background.
Thank you for that. Any other questions, Dr. Wright?
This was fantastic. Thanks so much for speaking with us.
Thank you for inviting me.
Thanks so much, Dr. Wright. We'll be in touch.
Thank you. Take care. Bye-bye.
Take care. All right.